physician at an oncologic center in Santiago, Chile. I am director of a radiotherapy program at the University of Compostales, and I was named as the Latin America SLAGO, the Latin America Oncologic Gastro Oncologist Association. So this is what we're going to see today. We'll go step by step. So first is my introduction. This is a relevant topic because colorectal cancer is the third most common in our countries, and hypercystic cancer is 1/3 of the colorectal cancers. And 40 years ago, we saw that locally advanced rectal cancer, which is the main topic of this lecture, we need adjuvant treatment. Surgery as exclusive modality isn't enough. Is historically, and with the Stockholm study published at the finding the 90s, the neoadjuvant is with short-term radiotherapy. This not only showed benefits with local control, but also benefit on the global overall survival rate. And in 2004, the classical SOUR study used long-term radiotherapy with concomitant chemotherapy before and after surgery, and it showed that it was better to do treatment before. So, which is the next step? So I would like to establish which neoadjuvancy is better. If we will continue doing the classical SOUR scheme or radiochemotherapy concomitant with long-term, then go to surgery and then eventually do more chemotherapy, which is a SOUR schedule, versus TNT, which today there are many modalities of total neoadjuvant therapies, but independently of the modality you're going to choose, well, which one is the best one today? And these we need to consider it because we don't have the issues in the 80s where the local control was the greatest issue. The local organ failure with exclusive surgery was around 25-30%, but in all the studies today, local failure is around 5%. So, and on the other hand, distance recurrence is the main problem, and most recurrences or relapses are going to kill patients. So this is where we need to focus, being the classic treatments, radio with concomitant chemo or short radiotherapy before surgery will have 30% of distance relapse. So that is the new thing we need to talk about today. And as Corrimarian mentioned in ESTRO 2021, the main reason to do total neoadjuvant treatment is to be able to treat early treatment with effective systemic treatment, all the metastases that are already at the diagnosis. And here we have that quick study that demonstrated what is really to do total neoadjuvant treatment. Effectively, we could prevent distance metastases, 7% of decrease of development of distance metastases, and also the Prodigy 23 study, chemo, then radio chemo of long term versus the classic, also prevented distance metastases. And the Stellar study also with a similar schedule to the quick study with short radiotherapy and consolidation chemo and then surgery also improved the free of disease over life survival. So I believe that there's not too much discussion about the classical SOUR schedule is part of the past, and that TNT in any of its variants. It's the new standard for locally advanced rectal cancer. Now we have an issue. There are different ways to do total neoadjuvant treatment, TNT. And this is something I'm gonna try to approach. We can do induction chemotherapy, then long-term radiotherapy chemotherapy, or do it inversely, first radiotherapy chemotherapy of long-term, then consolidation chemotherapy. And there are two trials that answer this question. The first one is the Theodoro 12, a German study that compares induction with 3-cycle focus, then radiochemotherapy of long term versus radiochemo of long term, and then consolidation with 3 cycles. The branch that won was the one that started with radiotherapy and chemo, concomitant chemo, then consolidation chemotherapy, and it achieved a better complete pathological response. And this is the branch that was taken to a phase 3 study. The other study that compares these schedules is the Memoria Slow Catherine study, the Oprah study again, induction with Folfox, in this case, 8 cycles. It was similar in KPOX, then radiochemotherapy, long-term course, and then the patients were reclassified to see if they could have a non-operate surgical treatment. And the branch B started with radiotherapy with concomitant long-term radiotherapy followed with chemotherapy, 8 cycles of Folfox, and then the reevaluation. Well, the results at 3 years of this study showed that the overlife free of TME of total mesosection was 53% versus 41%, favoring to start with radiotherapy and chemotherapy. So to start like that. So with these two options, I believe it's clear with all these randomized studies that to start radiochemotherapy is the best option that's starting with induction chemotherapy. Now, what happens with short radiotherapy and consolidation chemotherapy, like the Stella and the study Rapido or Rapid study? So I believe this is a critical point and happens, it's underestimated. This is the first publication of the study Rapido, which started in 2020. They show one of the main issues of doing radiotherapy and chemotherapy of long course, that during these 5 weeks, you lose valuable time. So they report that the branch with long course radiotherapy was a high number of patients with metastases, and they found it in the restaging before going to surgery, versus this only happened 1% of patients that went to total neoadjuvant treatment. And at the same time, this was also reported by the Prodigy 23, the TNT branch had the same exact number than Rapido, 1% with metastases when they were re-typified before surgery, versus the branch of radiation and concomitant chemotherapy of long course. They had great number of patients with metastases in these 5 weeks when you stop treating that micrometastatic disease. So for me, this is the main issue and the first issue of going with a total neoadjuvant treatment of long course. Let's look at that Rapido, 5 sessions of radiotherapy, 1 week, then after 2 weeks, that are very useful so the patients recover from the issues caused by radiation. They go to 9 cycles of chemotherapy, and this was compared to the classical SOURS schedule. This is a large trial, over 900 patients. And the other important thing with this study is that the patients these are the patients with the worst prognosis of all the randomized studies we've seen. They had to comply with these criteria you can see here: lots of T4, lots N2 disease, compromise of the mesorectal fascia, compromise of the lateral compartment, obtures or internal iliacs that are not in, don't come out in the resection. So this is a study that includes the worst prognosis patients of all the randomized groups seen until now. The only toxicity was greater in the experiment was 70% of diarrhea, grade 3 or large or over grade 3, but all other toxicities were lower than 10%. And they've asked me this several times. What happens with the surgical complications with short radiotherapy? Well, they were the same both for the standard classic schedule versus the experimental schedule. Surgeons, the oldest surgeons that did short course radiotherapy and surgery next week were afraid of short radiotherapy because there was no tumor reduction. There could even be some inflammation due to radiotherapy. Both things made the surgery more difficult to the colorectalologist. So this slide is very important to stop that myth that short radiotherapy can complicate the surgeon's life when you do after consolidation radiotherapy, chemotherapy. There are no surgical complications really, and the outcomes are as follows. Uh, Complete pathological response was multiplied twice from 14 to 28%. So you don't only prevent systemic disease, but you also, the skin is more active locally. So short radiotherapy is more active local folks for 9 cycles, increases the local activity. I don't know it, but the combination of both clearly shows that there's a better answer, duplicates the complete pathological response when you compare these with classical chemoradiotherapy. And you can see the Kaplan-Meier curves. There was a reduction of 7% of the mean outcome, which is uh, overall survival rate, failure of treatment. This is shows the metastasis at distance with no increase in the surgical complications, with a commitment of the quality of life. So this increase temporary situation of diarrhea, grade 3, and the experimental branch doesn't impact the quality of life of patients. Dr. Soler, before making this comparison of Prodigy and Rapido, I would like to ask you a specific question about the Rapido. So definitely, I believe you included the ugliest group. It's like the good, the bad, and the ugly. The Rapido really is the group of the ugly, that the one you don't want to see. But there's something when you talk about the restaging. So did in the Rapido, you don't have a protocol of which images you need to request before surgery, or do you? Can you please talk about this when about that? Can we talk about the restaging? What would you do if you do a short course? Do you give chemotherapy afterwards? Do you do a restaging before surgery to the patients, and what do you use? And another thing that I would like to know is that group that says that normal conventional radiochemotherapy, Capox after surgery was optional, and is one of the things that they criticize to this trial. So could you clarify these things before moving on? Great questions. Let me go back to this slide. So first is about restaging. I believe it's ideal to do everything again. It's one of the questions further on in this lecture, but yes, I believe that after all total neoadjuvants, you have to do a rectal duct. We have to do a colonoscopy, hopefully, and MRI and CT scan to see if there are distant metastases. So short answer is that after total neoadjuvant treatment, we need to do the four things we do before treating patients: TACT, MRI, rectoscopy, and CT scan. About, I understood that they criticize the control branch of the Rapido, that surgery is optional. Wait, adjuvant chemotherapy is adjuvant. It's optional. Is that, if that's a question, I this is what happens on a daily basis, more than a protocol. Many patients, after 5 weeks of radio chemo, 2-3 months to wait for surgery, and a couple of months to go to adjuvant chemotherapy. When you have this time, or the patient doesn't want, or it's not in conditions, but in the real life, it's not the majority of patients that receive this adjuvant chemotherapy after a classical course. In fact, the SOUR course was like this, and not all patients receive these adjuvant chemotherapy. So even the scenario of a clinical study, when we know have patients that are very well selected, very different from the patients we see in our daily practice, many of these patients don't receive adjuvant chemotherapy. So that is the reality. So they're comparing an experimental schedule against what happens on a daily life. So that is the most important point here. Thank you very much. So we saw some details of Rapido, and we don't have a study comparing like the Rapido against another TNT, so we cannot do cross comparisons. So from the statistical point of view, this is not perfect, we all know this, but until we don't have a better information, this is all we've got. So here's a comparison, both of the results of Prodigy 23 and the Rapido. If you look at the first column, they compare it against 17% of the Prodigy in the circumferential margin and of the mesofacial fascia. It's different both studies, but they're talking about the same thing. So in the Rapido, these poor prognosis factor is seen in twice as many patients, even though they started with patients that had a good prognosis, like Maria mentioned before, that in the Rapido, they really had the ugly, as the Europeans denominate them. So the pathological response were similar in both studies, and the overall through of disease-free survival was similar. So it seems like Rapido has greater activity or achieves the same results, even though the patients were in worse conditions. And this is not the only thing we need to consider, because until we don't know the superiority of one versus the other, we also need to consider practical things like which one is more convenient. And Prodigy 23 versus Rapido, and after radio chemo, the patient had surgery, and then there was post-op chemo similar to the classic. So I don't believe this is well, that makes me ask myself if this is a really TNT. But Project E23 uses one more drug, it uses more chemotherapy, and uses 5 weeks of radiotherapy versus one. So even if the results were exactly the same, from the practical point of view, it's less convenient because we are going to choose one that is less convenient. So I suspect that the Rapido study will have better activity as well. And if we compare it with the German study, behavior 12, it's the same thing occurs. The German study has 80% of T4 tumors, 22% of compromise of the fascia, almost one third, and the disease-free survival, overall survival, as it called in these studies, and complete pathological responses were similar. So same phenomenon. Rapido has worse patients and achieves the same results. So this makes us wonder that this is a more active schedule. And the same thing happens when you compare it with the Memorial Sloan. The OPRA study is the first important study that is randomized look seeking for non-surgical treatment. Well, they chose patients with less risk than the other two studies that I showed you. So here, T4 is just 11%. So just one third of the Rapido study. The disease is N0. Patients without node involvement, only 20%. In the Rapido was 9%. So again, you triple patients with a disease at zero at OPRA. So this is not focused in patients with better with so it's patients with better prognosis. Follow-up is shorter, and again the results are similar. And we should not discard that the OPRA study is a phase 2 studies with 300 something patients compared with the Rapido with a phase 3 trial with over 900 patients. So considering all these, you make the decision of which 10T you're going to offer to the patients. And if you compare it with the German and the OPERA trial with worse patients having the same results, well, I really suspect that the Rapido study is a more active schedule for patients with locally advanced rectum cancer. So my choice would be short course radiotherapy, chemo consolidation. I believe that is the most active schedule, and happily, this is another study that is being done, Colorado 18, the same German group now. They had the excellent idea of doing this trial where they compare, as you can see in the top, the branch of Rapido with short course radiotherapy and consolidation chemo. And these studies are going to see the non-surgical treatment as patients have good response. And the control branch is basically the OPRA. So we'll have finally, we're going to have a comparison of these two treatments, because in one branch we have short radiotherapy, the other one radio concomitant chemo, and probably this study will help us define the standards for the next couple of years. This is privileged information I had because since this question is so interesting and everybody's asking it, this study is recruiting in an accelerated manner patients and has 2/3 of the patients they required. I'm sure they're going to have enough patients before they considered. I'm sure they're gonna have very answers very soon, but it's impossible to know in less than 2 years. So I hope this study helps us to determine what we're gonna do in the future. Here are more details about the study, but in few words, this is a comparison of OPRA versus Rapido in order to seek non-surgical treatment. Dr. Sole, we have a question from one of the participants. Okay, so the standard today is TNT, but which patients today do you believe? Because I know you like short and Rapido really is your treatment of choice. But which patients today do you feel that are of this selection of Rapido and you would say, okay, I would do chemo long-term chemo radio, then oral treatment, and then so this is one of the questions of our participants. Great question for what I'm sharing with you and what I'm still missing to say. Where for the uglies, the best option is to do rápido protocol. And I believe we shouldn't discuss that too much. What happens with patients that would like not to have a surgery and have a less risky disease when the low rectum would like with a 2 0 and O and 0 2 10 T2 and 0 the lower rectum. Well, these patients have low possibilities of distant metastasis, so there would be no less urgency to do oxaliplatin treatment to prevent micrometastasis. So that wouldn't be really the typical patient for that TNT was developed for. But if a patient wants to avoid the overall survival free of colectomy, and that patient will have a long schedule, will have good results, high probability of avoiding abdominoperineal resection, and I believe yes. Now, my question again is, what will they gain with 5 weeks of radiotherapy and chemotherapy versus doing just 1 week? I'm not sure. So, even though I believe in these patients, it's important to do a long schedule. I believe it's not better than a short one. So, probably it depends of the physician, of the resources, availability of radiotherapy, and other things. And these we'll talk about these later on in this lecture because this is one of the most important questions. Okay, so yes, I know you're going to, let's discuss this topic later on. Thank you very much. So this is the novelty, and this is what makes interesting, especially interesting, this lecture today, because we're going to talk now, according to the last publication of the Rapido study of 5.6 years of follow-up. So the question is, local control with hypofractionated radiotherapy is worse than long-term, long course? Well, this is a question that you need to ask yourself, and I want you to also answer it. So you can see the poll. You can answer yes or no, which is worst? Local control with, is it worse to have local control with hypofractionated radiotherapy? Let's wait until the half of all participants answer and then we will check. Very interesting. I wasn't expecting this. Well, so I don't have to convince you. More than convince you, I need to reinforce what you're believing already. I'm glad to see these. I believe, like I think as most of you do, I think it's not worse. Local control is not worse. And as Maria mentioned, I am very biased in short course radiotherapy. I believe in Papilio. Probably I'm not very objective, but I have my arguments. Now, as I am biased, and I did a mental exercise, and I said, okay, maybe I'm not the ideal to answer this question. So, with a colleague that is rotating in my clinic, a colleague from Peru, Dr. Simon, I asked her, she doesn't use short, she's a young and has less bias, at least less bias than I asked her to check local control in all the important trials that randomize short course versus long course radiotherapy. And this is how we got this slide that I am so thankful for to Dr. Sonia from Lima, Peru. who helped me to achieve this conclusion. You see the large hypofractionated versus long radiotherapy in 8 out of 9, local control was the same. Only in this publication of the Rapido study, the long course had a better local control. So when you see these, when you compare two treatments, whatever they are, compared to the outcome, 8 of the 9 studies say that they're the same, and only one says that it's different, then you must stop and say, okay, you don't, this is really due to the different branches that were, well, it could be due to other factors. So that is why this paper published recently in this journal shows that hypofractionated radiotherapy has 10% of local regional failure versus 10 of long-term radio chemo. But these are, it has clear reasons. They have enough reasons to, there are enough reasons to explain that difference of 4% in the local control, which is one, I IMRT wasn't standard. There were several patients that had 3D radiotherapy, and curiously, there were more patients with poor quality radiotherapy or 3D radiotherapy in the experimental branch, where P was significantly different. And I, who have done radiotherapy 3D, 3D is anything. 3D doesn't require the contours of the targets. The margins, of course, in general, it does include images every day before each session. So there's a difference in the quality that is very important between NMRT versus 3D. So maybe it's not of the calculation technique, but of how radiotherapy is done today in the era of IMRT, where you check all the margins, you specify, et cetera, et cetera. So unfortunately, the hypofractionated branch had more patients with 3D than with IMRT, and that was has a significant difference. And in local, the local control was worse in patients with 3D RT than with IMRT. And this corroborates that 6% was achieved in both branches with IMRT. So local failures are in around 5%. Here was 6%, which is basically the same. In the ugly patients in the two branches, it was the same. So they had a longer follow-up than majority of randomized studies because we have 5.6 years of follow-up. So you should not be afraid of local failure with short radiotherapy and quick chemotherapy. And the other important thing is surgeons convinced us for over a decade now that the quality of surgery is important. And how is it going to be important in the ugliest patients that we've had in the randomized studies? TME, even though there's no randomized study comparing specifically TME, but it's broadly considered the standard treatment as surgical management in rectal cancer, which shows us that quality surgery is very important in this disease and will be even more in patients with worse prognosis that we've seen in this study. And even though the branches at the beginning, both the experimental as the standard, were were similar in terms of the size, the location, and the number of patients, both branches started with the same patients, but we see a very interesting phenomena, which is that in the experimental branch, There were more patients with anterior resection, and in the classic branch, there were more patients with abdominal perineal resections, and this difference was statistically significant. So it's hard to explain that phenomena because with the same patients to begin with, one uh, some had more surgery, more conservative surgery, to say it somehow, in the experimental group. Probably this was due to a change in the therapeutical treatment. The idea was to have surgery in all of them. It was not non-surgical treatment, but since there was a better clinical response in the experimental branch, we know that they have was a better local response because there was complete pathological responses. But these better clinical response made surgeons to make a more a smaller, more economic surgery, and many of these patients that had ugly cancers, T4N2 and B positive, CRM positive. So these two characteristics that were more frequent in one hyperfractionated branch perfectly explain the difference of 6 to 10% in the increase of local regional failures. And finally, even though those failures, I insist it's not true due to the reasons I mentioned, but in case it was true, even though the final endpoint is still in favor of the hypofractionated branch, considering this increase in the local failures, still there's less treatment failure in the experimental branch. And finally, one would say, well, there are no local failures, so these could be rescued. That's different, more difficult when you have a distant metastasis. So the final endpoint is it's still in favor of the experimental uh, branch. So even though there is one study shows more local failures, but the studies comparing the survival rate, free of disease, free of failure, or even global survival, overall survival. Well, there are three of these nine studies that have a better survival against one that shows one a greater local failure in hypofractionated therapy. So three studies show better survival with a hypofractionated. So here you have the nine studies: Estocolmo 3, Polaco 2, Prodigy D42, the Stellar, etc., and the Rapido. So they have worse local control with hypofractionated therapy. I really doubt it, and I'm really happy that you think you believe it as I do, even before I showed these analyses. Other relevant topics, we've been here for 40 minutes already, so I'm going to go quicker on these. You can do hyperfractionating lower rectum. I think this is the best evidence to answer this question, which is this. This is a meta-analysis of individual analysis of randomized studies of short versus long radiotherapy. And since it has individual data, it includes only the patients of each randomized studies that had low rectum location. And you can see there's no difference between doing long versus short radiotherapy. Even that rombo of summary is in favor of the short course, but the conclusion is that you should not discard short radiotherapy due to the location on the lower rectum of the tumor. So yes, it can be done. And the other thing we need to consider, these surveys sent to patients with rectal cancer. Of course, 76%, three of every four patients, said that the most important thing for them was to be cured. But curiously, 78% say that's more important not to have a permanent stoma. So This is something we need to consider in the future. The non-surgical treatment is a reality. It's something patients want, and you need to look for these well-selected cases where we can achieve these. So we need to ask ourselves, okay, so what happens with hypofractionated radiotherapy in that
Hay que
short
preguntar a
course?
los participantes entonces
So
en
let
este
me ask the
momento
participants.
para
So
que vean
now,
que si ellos creen así
do
que se puede
you
hacer radioterapia
believe
fraccionada de
that you
manera
can do
ambulatoria, entonces
hypofractionated
siga para ver qué
radiotherapy
hace
in
y es lo que
non-surgical
preguntan ellos.
treatment? So let's see what they answer. Okay,
Digamos, bueno,
here the
entonces los
proportion changes
participantes
a
están
little
como
bit. We have more
pendientes,
participants that say
pero
no,
igual bastante sí. Entonces,
but many
vamos
say
a
yes.
colocarles
So,
los resultados.
doctor, so here are the results. Okay, I'm also surprised, favorably, positively surprised by this. So we just have two slides about this. So this is a trial, the management of non-surgical management with short-term radiotherapy. One of the authors was Gasparic, was 10 years ago, 10 days ago in Chile. He was showing us this data and we were talking about it. And this is a very small study, really, but with promising results. You see the complete clinical response at 1 year was 68%. And the patients that achieve this complete clinical response at 1 year, at 2 years, they have a survival free of metastasis of 100%. But focusing again in that non-surgical management of that 68% of patients, which is a great number, it's a spectacular number, because please recall the data of the OPRA study that is taken as a non-surgical treatment reference. They have a TMRE a survival of 53%, and here we have 68%. So it's true, this is at 1 year, OPRA is at 3 years. So probably in the next 2 years, we will see some local failures in these patients, but I really doubt that it will go from 68 to less than 53%. I really seriously doubt it. And the next thing, which is a non-randomized comparison presented in ASTRO 2021, comparing different centers in the US doing non-surgical management, and separated the results of the short course versus the centers that are doing long courses. Short course, 85 patients, long course, 102 patients. And again, this is a non-randomized study, and the clinical response, complete clinical response, was higher in the short course. Look at the first arrow, 58% versus 20%. So yes, they conclude that short course in TNT management, non-surgical management, is comparable to the long course without having or having not having a worse over disease-free survival rate. So it's good to manage non-surgical, to do non-surgical management of this disease. So I totally agree with the 80% of you that agrees that you can do short course with hypofractionated radiotherapy. And besides that, there's something of logic, of common sense here. When you see that the most active branch of Rapido was with short course chemotherapy, and they doubled the complete pathological responses, that tells us that that scheme is more locally active than long radio chemo schedule. So we have some data from Latam. Yeah, of course, it's not only this, we have our experience, which I shared in the table comparing the Sauer publication. We, with only four folks, with which was the Washington schedule that's reported here, we had complete pathological response, 28 versus 8, and a downstage of 65% versus 50% in the Sauer. So for us was never go back, never look back. This has been already published, was presented at Astro. and also colleagues from Chile from the University of Valparaiso show excellent results with short course radiotherapy, 3 plus 3 cycles of chemotherapy with the publication of Rapido. They changed it and now they're doing a little bit more chemo. So this was just to show you the experiences I am familiar with. And finally, we are going straight to how to do radiotherapy. So please stop me because here I'm really interested in you to stop me because I don't know if things are too obvious or they are very relevant and we need to talk on deeper. So we do it from cubital supine. We do mildly full bladder with a vesicle roof. The idea is that the roof of the bladder, we don't want it ultra full because it will be difficult to reproduce, but not very empty because increases the Sorga positions and we have lower intestine, so we have greater uh, radiation to the rectum would be ideal to be empty. It's not easy in these patients, but I look at patients and check the bladder, the rectum to see if there gas, or we ask the patient to go to the bathroom and to go back to the simulator if it's full, if the rectum is full. Sometimes this is not possible due to the position of the tumor. So we do scanner cuts every 2.5 millimeters. We fusion the exam images. Sometimes it's not possible because the images are come from other hospitals and they're not compatible. But we do need these images. The contours, I'm going to talk about these in more detail. We do VMAT in all patients and rapid plan with AI that allows to optimize and homogenize the calculation within the different dosimetries too, so we all have a higher level. So we are not, if you, so we don't have issues with the doses if we have a more junior uh, person. I need to confess that now we're doing conveam CT to all our patients, and I'm going to show you why. Right now, I would like to invite two participants who sent questions and were willing to open their microphone. Dr. Francisco Lopez, he wanted to ask you a question about the inclusion of inguinal nodes. So I don't know if Dr. Lopez would like to ask his question. Yes, here I am. I can hear you very well. Good morning, Francisco Lopez from Nicaragua. Doctor, I would like to ask you two things, or three in fact. If you recommend to contour intestinal sac or an loop in the PTV, do you have any constraint to evaluate these depositions or you do a resimulation? And the third question, in patients with positive ganglion nodes in the groin, what would you recommend fast? Very interesting question about the sac. If there is these crosses with the PTV, you have to, it's not discussable to, this is another disease. Patient has to be willing to have a toxicity. This is a very different scenario when we radiate the prostatic ganglia where we cut the gut. We need to uh, draw loop by loop. So even though we draw the intestines, we place a constraint that you can place later on, but it's not very restrictive. And for no reason, I would diminish the CTV. I wouldn't, no, I would include the intestines. We need to privilege the CTV that the target to receive a good dose. So I hope this answers your question. I'm going to talk about that later on in a couple of slides, later slides, about patients with groin compromise, P4s in anterior organs, when advanced bladder cancers, for example. Of course, I recommend this, and I base myself on what I mentioned before. Patients, the ugliest patients or most locally advanced that have gone to a randomized study in the history of the disease were in the Rapido study. So for me, there's no discussion that these patients need to be use this schedule. It's not. It's not good to It's not uh, important. There's no reason to discuss this. So if you also have external iliacs, we don't have problems with these patients either.
Listo. Lo dejo seguir y ahorita invito a otro de los
Okay.
participantes en una pregunta que es más sobre la técnica y MRT
So
como
thank you, doctor. So many years ago, we developed a guide to learn how to do this in a more systematic manner. So the results of the contours of different physicians were similar. The guide in reality is this one for for whoever wants it. I can send it via email, but I tried to summarize it for these lectures. So first thing is to start from the middle to the edges. So start with GTV. Once you draw it, you make a circumferential expansion in the axial plane of 1 centimeters, caudally up and down of 2 centimeters. And of course, when this expansion falls above the bone or a muscle, we need to avoid it unless it is compromised. Then we draw the internal iliac vessels from the promontorium until these vessels leave the pelvis, which is like 1 centimeter above the pubis, or but it could vary on each patient. Then we do the CTV of the iliac nodes with an expansion of 50 millimeters, and then we avoid again bones and muscles. Point 0.5, excuse me, 0.6. We're going to do the presacrum contour. We use the brush, not the pencil. We use the brush with a diameter of 15-20 millimeters. We get all the promontorium, the sac, all the way to the last sacral vertebra. And in C3, C3, we have the piriform muscles. So we don't include S3, we don't include the muscles, the obturators, with the same brush from the bottom, from the notch, and then we stop when we get to the joint. Then we make a circumferential expansion of the meso of 10 centimeters to give a margin for the vesicle or intestine fillings the patient might have. We also avoid the bones, and then we conglomerate all the CTVs in one. We make a CTV compromise with all the previous ones, and we do a PTV that should be at least 10 millimeters if you are not using Combi CT. And we draw risk organs, bladder, um, femoral heads, the intestines, the bowels. And here it is step by step. So when you sit and do the contour, we don't do it in all the cuts. We do it every 3 cuts, but to have all the same contours, you can add everything and make an interpolation. And that way we can save time as well. We use IMRT. There are several studies, mainly dosimetric studies, that show the benefit of IMRT. And Before moving on, Sebastian, with this step, because this question from Ben is very important in terms of contours. If when you are contouring the GTB, do you contour only what you see in the lumen with tumor, or you consider the whole lumen to make that expansion? Great question. The whole diameter of the tumor in the compromised rectum cuts, we do the whole diameter because the rectum is going to be in different positions, will have different amount of gas, different amount of, it's not a fixed organ. That's how we've done it all these years. And all these contours that are more restrictive come from these radiosurgical treatments, but no. So I think the concepts are different. We need to check the nodes. We have some anatomy that's always changing. So if we're not taking cone beam CTs in each session, we need to have safety margins. So as surgeons said that TME is the standard without randomized studies showing specifically that, but with non-randomized evidence, well, I do believe that IMRT should be standard in these patients because dosimetrically is better. And the dosimetric analysis are correlated with the clinical results of toxicity and effectiveness. So this is a visual reason why it is better to the B and E pictures are 3D, where you can see an important portion of the bladder and the small intestine, and you cannot do it. So these are the constraints. Visually, they're more attractive. For the targets PTV, the minimum of PTV is T9595. It's ideal for detectability and T9390. And if there's an interposition with healthy organs, we don't achieve this when it's a minor deviation, but it's stable. I believe that T95, that 95% of PTV should be covered. Maximum points, V 107, hotspot 107% of the dose less than 2 cc, and 110% of the doses less than 0. Excuse me, 0.1 cc, and a minimum coverage of CTV, where 100% of CTV must have as an objective 97% of the dose with a minor deviation on 95% of the dose. Constraints for to risk for risk organs is not too complex. To have cuspids, we don't accept in general hotspots on the 25 grade. Dosimetrical aspects, all our patients go with cone beam. We use with VMAT 1, 2, we use complete rotation arches. All patients with 6 MV are calculated with a dosimetric software called Rapid Plan. And what I was telling you before, we're doing IGRT with cone beam, with CBCT. Before starting the cases, Dr. Sole, I would give the floor to Alejandro Blanco, who had a reflection about IMRT and 3D CRT. I don't know if Dr. Blanco would like to open his microphone now. Yes, thank you for this attractive lecture. I have a reflection about this disjunctive about the relapse in the rapid dose study. I think we are all surprised by this. I I am a true follower of hypofractionated treatments here in Costa Rica. These are schemes that we use on a daily basis. One of the reasons that in that same study it says that could be the explanation of this local failure is related with different radiotherapy techniques. Nevertheless, I believe this is something we have to be very careful when we handle this because it's IMRT is not more effective than a 3D RT. Looking at the article, they assume that 3D has no segmentation of the structures. Most of our countries, or at least here in Costa Rica, frequently we do 3D, but we all do it with structure segmentation through the simulation. So I believe there are meaning patients with 2D that well that been that as defined through bone the references are volume to treat. But what I do agree is that impacts an MRT in any of its modalities with a rapid arc in the dose of the critical organs. But I cannot be so sure that there is a significant difference in order to explain a differences in local failure between patients in 3D done with simulation by CT scan and an IMRT in local control. So I do agree on the adverse effect on the critical organs. Besides that, if we check the studies where there was no difference in the local control with a short course, most patients were treated in 3D, an era where IMRT wasn't as common. So it's hard for me to say that this could be an explanation. I think we should not be alarmed. There's enough evidence to keep doing this, but I wouldn't agree that this is an explanation. On the other hand, comment about the short course in non-surgical patients. The two studies are is little information. It's hard for me to say that those who are not surgical all require chemotherapy. We have had patients with CT2, CT3, and zero with MRI that we are not going to expose to chemotherapy, especially if they're elderly. So we have to have more information. Most studies talk about a long course or sphincter conservation in lower sphincters. And I'm sorry I took so long, and thanks again for your lecture. Okay, I think we are almost 100% on the same. When you said 3D on both branches, the local control is the same. The thing here is they have a different use of 3D on the experimental branch versus the control. So I am 100% with you that 3D today in 2023 is absolutely different to the 3Ds I did in 2008. But we don't know that in the study. The study is, well, it was done a while ago. So when those patients uh, that started 10 years ago, I suspect that many of those patients that received 3D is not the 3D that we understand today with contours, dose analysis with advanced software, etc. So, since we cannot discriminate, or it is not, or the study is not discriminated well, it would be great to have a clarification of these 3Ds if they were done with contours of the target, how many were, how many weren't. We don't have that information. The fact that many patients receive 3D and greater local failure makes us suspect this that since 3D has no definition of what needs to be contoured, well, many of these patients could have not been contoured. So I understand that today, if your standard would be IMRT with an linear accelerator was broken, if in that patient you will do a 3D plan, probably you won't have a deterioration in the effectiveness of the treatment. Maybe there will be greater toxicity. But I do agree with you. 3D, well, we don't know what type of 3D it was. If it was with contours, like we understand it today, like my residents are learning now, or what we did 10 years ago, which was basically place bone limits with in a simulation scanner, and everything was contoured automatically in the midline. That was it. And about the non-surgical management, maybe it's true what you're saying that you overtreat some patients with small tumors in the low rectum that doesn't want to have surgery. But since we still don't know it, I would rather do a over treatment with more chemotherapy to achieve that, um, to avoid the perio abdominal resection. If you don't have complete response, you can manage non-surgical treatment. And from my point of view, it's hard, a worse toxicity, a worse overtreatment than an abdominal perineal resection and a permanent stoma. So until we don't define the more specific protocols for subgroup of patients with better prognosis and smaller tumors, I would rather over treat with chemo and radiotherapy because the main objective there is to avoid surgery. Because I do believe that a abdominal surgery does affect permanently the quality of life of these patients.
Perfecto, muchas
And
gracias por
thank
esa
you very
respuesta.
much
Es
for
muy claro y muy importante esta
your
discusión que nos plantea el doctor Alejandro
opinion.
Blanco. Por último, antes de
Okay,
continuar con
thank
las
you for
preguntas,
your
le quiero dar la
answers.
palabra
And
a David
finally, I want to give
Martínez,
the word to David
que tiene también otra
Martinez,
pregunta para
who
usted.
also has a question for you.
Una pregunta y un comentario. Entonces,
A
digamos,
question
con
and a
respecto
comment.
a este
Okay,
último
so
comentario del manejo no operatorio, para los
non-surgical
tumores T2, T3 tenemos
and
el
T2,
resultado
3,
del Opera
T3
Trial, ¿cierto?
tumors, we have the
Y
Opera trial
ese último
results where
brachytherapy pues nos llevó
doing
a
boost with
resultados de
therapy led
control
us to
bastante
local
buenos, ¿cierto?
control results
Bastante
that were very high, very good,
promisorios en este
let's
grupo de
say
pacientes. Entonces,
promising for this group of
quizás
patients.
otras
So
alternativas de
maybe
escalamiento de
other
dosis con
alternatives
radioterapia, en
to
este caso,
escalate with
podría ser una
brachy could be
alternativa
maybe an alternative
que ese
considering
tipo de tratamiento
that
fue con
this
poco
type of
recorrido.
treatment
Entonces, digamos
was
que
with long
el
course.
ideal hubiese
So
sido, bueno,
the
hagamos
idea would have been,
un boost
okay,
con
let's do a
brachy
short course and boost with
pero
brachy
eso
to
podría
see
ser
what
una
happens.
pregunta que uno se
So
podría
this could be a
plantear en algún
question that
momento.
we could ask
Otra
ourselves
pregunta
in the
que
future.
quería
Another thing
comentar
that
es
I would
que
like
todo
to
este
add
estudio
or
muestra
comment
que
is
quedan en
that
este
this
WISE
that Sebastian is showing us
cómo
in this
pintar
wise approach of
es
how to
bastante
paint
importante porque
is
esa es la
very
adherencia
important
a que
because that's the
todos
adherence
hagamos
that
los
we should
contornos
all
de la
do the
manera más homogénea
contours
posible.
in the most
Desde
homogeneous
un punto
manner
de vista
possible. And here's something to highlight. We can
quizás
all
no
paint
sabemos
differently,
muchas
but
líneas,
the
pero
more we adhere
digamos que
to
los
the
resultados de los
guidelines, the
tratamientos van a ser
results
lo más
of
homogéneos
treatments will
posibles.
be
Y aquí
more
mi pregunta
homogeneous.
es, ¿en qué
And my
pacientes
question would be
considera
here,
que
which
un
patients do you
boost,
consider to do
digamos, en
a
facta
boost
3 en 5 fracciones,
to
diagramos de varios
30
tipos
grays in 5 fractions
podría
in
considerar?
the notes? Thank you very much. David, generally, I don't talk about opera. It has great results, very desirable results, but I don't talk about opera because it's very little reproducible. So if you are in France and I had rectal cancer, well, probably I would go and have treatment there. But I cannot reproduce what they're doing, and most of those who are listening to this lecture aren't either. So it's very interesting study, but I believe it's not too practical for most of us, at least up until now. About the guidelines, I would like to say something that I had mentioned before. Of course, those guidelines are not my invention because I'm so wise. No, it's just a way to summarize all the guidelines. There are Canadian guidelines that are great, and placed in a practical manner, step by step. They are there, so we have the same results as the guideline. But I believe you can all use the guidelines that you want. For us, it was very interesting to do it this way, practical, and this is how we do it on a daily basis today. About the boost, I always boost the compromised nodes in the lateral compartments because in general they don't live with a total mesorectal resection. So if you see large nodes or obturator nodes, I believe you need to boost them independently of the radiotherapy schedule. We do 25/5 in general. We do go to 30, yes. With MRT, IMRT, you can do a concomitant boost or simultaneous boost, which is easy to be done. And it's logical because those lymph nodes are not going to be resected. So I believe we're helping the patient when we are doing this thing. Okay,
Gracias, ya.
excellent.
Más o
The
menos
boost question
entendimos
was,
al doctor. Muchas gracias. Y bueno, sin más,
it's very clear.
podemos dar inicio a los casos clínicos que nos
So we
trae
can start with the
con
clinical
respecto a
cases.
nutrición.
We're going to go faster. Stop me if you think there's something that we need to talk about. So this is a patient assigned 2020 during the pandemic, 46-year-old patient with rectal bleeding. He had a 3 centimeter bleeding at 6 centimeters of the anal margin, adenocarcinoma infiltrating. I didn't think it was an ugly tumor at all since we studied. How do we study this? This is the question I have for you guys. How would you study this tumor?
Aquí
Oops,
está.
here's the
Entonces
poll.
recuerden, ya les aparece las
So
anotaciones.
you
En caso
can
de que tengan algún
see the
problema con el
poll.
Zoom y no les
If
salga,
you have
recuerden que pues la pueden mandar por el
an
chat
issue,
sus
you
respuestas.
can also give your answers through the chat. So I'm going to
Entonces
wait
anotan
for a
y
couple more people to
verificamos un
answer,
poquito
but
qué
I
estudios
think we
deberían
can
cada
see
uno.
which studies they would order. So these are the results. Great. I think you couldn't add more than one answer. So I agree, IMRI is the most important study, but it's not the only one we must do. In general, PET scan, we don't do it as a routine. Endosonography in the practice, we never ask for that one. The MRI gives us more information. 0.5 is really interesting because the study from the Memorial Hospital shows patients with microsatellite instabilities or deficiency of repairing of the mismatch could have 100% of complete clinical response, avoiding chemo, radio, and surgery if you do immunotherapy. So even though we're not using this today, I'm sure that very soon we will have to adopt. There was no metastasis. The MRI showed a 5 centimeter tumor with invasion on the mesorectal fat, three suspicious lymph nodes in the mesorectal. So we're talking about 3 MR positive. So these are all the treatment options. Direct surgery, long radiochemotherapy and surgery, and then evaluate adjuvant chemotherapy, short radiotherapy, surgery with or without delay, TNT with short radiotherapy, then FOLFOX times 9, TNT with long radiochemotherapy, then FOLFOX times 8 for consolidation, and TNT with chemotherapy, and then radiochemotherapy, as in the Prodigy 3.
Voy a esperar que tengamos un poco más de la
Let's
mitad de
wait
los
until we have
participantes
more
que
than half of the
su respuesta
participants
sobre
and
qué
to
harían
answer, know what they would do with this
y
case
cómo lo tratarían ustedes en su centro.
and how you would treat it at your center. Okay, doctor, you can see the results there. Sure. Yes, I see there's surgeons here in the audience because a non-surgeon would not decide to do surgery. So let's move forward. Of course, we offered short-term radiotherapy, short course radiotherapy. We reviewed the contours. I can show you the actual plane. At the end, we created the GTB, the whole diameter of the circumference of the rectum, not only the tumor. You see that on the sagittal plane, maybe this patient, the bladder was a little bit fuller than we wanted. We like the roof to be like over here. Just imagine a line between the promoters and the upper pubis. Here, the body is a little bit larger, so it's going to be harder to reproduce these on the treatment day. Different axial cuts here. This is the first expansion of the GTB, 1 centimeter circumferential and 2 towards a caudal cranium, as you can see in the sagittal plane. And this craniocaudal expansion is done there just on the digestive tube. That's why it's like tightens. Then we have the mesorectal contour that it's pink there, and in green, the expansion of that mesoderm. That goes all the way up. We go all the way to the promontorium. There's another contour that's brown, is a presacrum. And it's very important here, different to what we do in prostate cancer. We need to introduce the contour in the sacral holes so they are well irradiated in this area. This is in the presacrum areas where we need to do this. And probably this helps not to for this to happen. So here we contour the vessels on both sides with the expansion of 1.5 centimeters, circumferential expansion, but they're edited on the operator, and behind you can see that the periform are edited. And finally, the operators try not to include them. A brush diameter of 15 to 20 millimeters from there upwards, as you can see, not including the external ilia, but it's rarely to do this. You need to include the external iliac vessels, but there could be fixed in the sacrum on the right. Here we see that white spot. So here we have the sacroiliac joint. So this will be one of the last cuts upwards of the including the operating territory. And finally, all these was we added with in a one CTV that I'm showing you right now. And we give a PTV. And if you don't use compensity, the PTV should be at least 1 centimeter, minimum 1 centimeter. So please consider those. Here you can see with the dosimetry of the same patient. You can see on the lower bottom left, 2 fields, one clockwise, the other one counterclockwise. 2 arches are used standard. And here the prescription, these 5 grade, 5 sessions at 100%. And here we have the constraints that intestine, the bladder, the femoral heads, etc. So this patient received short course radiotherapy finishing September 2020, and then the Folfox that ended February 2021. What do we do with this patient? We restudy him, yes or no, and why? We already answered at the beginning. I don't know if we should just move forward because we already answered this one, okay? So we decide the digital rectal test and endoscopy. We did the test. Here you can see them, so you can believe me, the impression of the MRI, no signs of compromise on the here. The surgeon was not very enthusiastic about non-surgical treatment, but he saw that there was total regression of the tumor. So we offer watch and wait to this patient or surgery. In this case, I mentioned that surgery due to the location was abdominal perineal resection. And so here, I do believe we should ask a question. So
van respondiendo. Tú haces la rezo a las 6 a 8 semanas y luego
You
esperas
do rest at 6, 8 weeks and you wait until 12 weeks, or when do you make the decision? The MRI. I'm going to
Sin título, discúlpeme. Y si
have
están
a
de acuerdo
votation
en
without a
este caso
title.
con hacer watch and
If you
wait,
agree to
sí.
do watch and wait,
Y si no
yes.
están de acuerdo y su opción
And if you
sería
don't, then
la
your
cirugía de
option would
resección abdominal
be
perineal, pongan no.
abdominal perineal resection surgery.
Mari, me escucharon ahorita, no, quería preguntar.
Can you hear me?
Entonces
Yes.
lo voy a abordar.
Dale, perfecto.
Bueno, watch
Súper, mira, esto era el año 2020, ¿ah? Así que no
This
estábamos
was in 2020.
watch and wait.
Watch and wait was in 2020. And happily, this patient decided for us because he rejected abdominal perineal surgery,
Que fue lo que se le ofreció.
which was what we offered.
El último
Last control was last year,
desde el diagnóstico,
April
o sea,
18,
2 años, 8 meses
32
de
years,
seguimiento,
8 months after the procedure.
vida absolutamente normal,
He has an absolutely normal life
a tiempo
with no
completo,
sequela. He works full
y
time
tiene
and
exámenes de
has
imágenes que
no
aquí
imaging
la resonancia va a la
test
izquierda,
here. You can see the MRI
4 de abril del
done
2023,
April
control
4th,
retroceder abdomen,
2023,
está sin secuela
control
recidiva,
of
y colonoscopía que
with
fue
no and a
hizo el último
colonoscopy again
coloproctólogo, así que
done by the
imagínate que venía
coloproctologist.
con
So
un
just
dato
imagine he
alto
was so
en
wishing he
probabilidad
could find
de
something, but
incipiente, pero sigue
there
buscando un
was,
manejo no
this is a
quirúrgico,
beautiful case
no
of
operatorio,
non-surgical
de
treatment
recurso corto y 9 ciclos de
with
Folfo.
short course
¿Habrían sido
radiotherapy.
necesarios los 9 ciclos de
So
Folfo?
should we have
Tres,
used the 9 Folfox
quizás 2
cycles,
ciclos
maybe
sobre
3
5.
or
Yo creo
maybe
que no
5
tenemos idea
fluoroside?
porque no
I
tenemos
think we don't
información
have any
exacta.
idea. We don't have that answer yet.
Mediante el grupo
Brazilians
de Abergama
and the
y
group from
Rodrigo Olivia
Avergrava
Pérez
and Rodrigo Olivia
hacen un
Perez
estudio que están
are
randomizando
doing a
a
trial, randomizing
hacer luego del
to
primer
do
quimioterapia, hacer solo
after long
fluorouracilo o
only
oxaliplatina para ver si
we will wait for those
funcionaba.
results to answer
Por
this
lo tanto,
question
yo
until
sí
we don't
creo que
have them.
agrega
I do believe
que
that you should add it
con los
because
pacientes que hemos
with
tenido,
the patients we've had,
a ver, si comparamos, por ejemplo, la
if
radio
we
de
compare, for
raíz con
example, the branch of only radiotherapy of Stockholm 3
radioterapia corta sola
of
y después
short
para la cirugía,
radio with
la radioterapia
delay for
corta
surgery
sola
radiotherapy
tuvo solo un
alone
10% de respuestas completas.
had only
Y
10% of complete
no eran tan
response,
malos
and
como los
those
de la rápida.
patients were not
La
as
rápida
ugly
tuvo
as the Rapida.
28%
The
de respuestas
Rapida
completas.
had 28% of
Hasta
complete
no tener mejor
response.
evidencia, yo creo que el
So until we don't
oxaliplatina
have
sí
better
agrega para el control local.
response, oxaliplatin adds for local control. About restarting these patients, well, the patients like under a TNT protocol, independently of the type of radiotherapy, will go after several cycles of chemo, 8 in opera, 9 in the rapido. I believe that immediately after last cycle, we have to do it immediately. The retypification with MRI, with digital test, with rectoscopy, and abdominal thorax scanner. Because 4 months have gone after the radiation in both cases. So after finishing chemo, I think you should not, you don't have to do it immediately, but I don't see any reason to wait. Case 2 is a patient I saw in 2016. The interesting thing is that I'm going to control him. I followed him closely. He has, this is a 62-year-old patient. He had only one scanner. He is not a wealthy patient. So in the scanner, we have so many node metastases. Colonoscopy, even though it was an experimented colonoscopy, he couldn't go to the caudal. So he found this tumor of 7 centimeters of the anal edge, and the antigen was in 17, over 3 times the normal value. And on the digital test, the tumor was at 6 centimeters of the margin. The patient had many symptoms. At the end, we did it without the MRI. The main value of MRI was to typify, give a prognosis, but the patients who already knew they had an advanced rectal colon with distant metastases. So we didn't dare due to the symptoms to work. And this question, we already made it, so I'm not going to repeat them. Look at the scanner. As you can see, a huge tumor in the rectum, in the actual plane. You can see to the left. On the right, you see a mesorectal neopathy that was not minor. You can see the contour of the GTB, how that adenopathy was so close on the primary. Here, more towards distal, we see another adenopathy to the right on the mesorectal. Here we see a adenopathy and a large tumor. The contour of GTB goes from the coccyx to S1, S2. So this was a really large tumor in this patient, plus the adenopathies. You see the expansions where you avoid the bone, the coccyx, the sacrum, and the expansion, caudal expansion that goes just through the intestines. GTB, we follow the intestine 2 centimeters up, 2 centimeters down, please recall this. And here we can see the same thing. Here we see another adenopathy on the mesorectum, another presacrum that was very high, almost on the promontorium, and here another presacral, a little bit larger and lower to the left of the midline, and another low presacral. So the patient had lots of disease. The contours here, more of the same. We're going to move forward quickly. Here's an interesting question, and I didn't realize that bladder looks a little bit empty. So would you have a special consideration? Because one of the participants mentions it, and I think it's very relevant because yes, we see an empty bladder. Yes, this is a poorly prepared bladder. This is a patient from 2016. We were not as strict with those things as we are today. The fact of using cone beam CT allows to see the anatomical changes between the sessions. So that in reality, this patient is poorly prepared from that point of view. So I totally agree with this observation. If you see in the sagittal plane, it's lower than the imaginary midline. So we have to have the promontorium at the upper edge of the pubis. So yes, I totally agree with the comment. In the actual plane, we see that this is the last contour of the obturators, like looking at the lower ridge of the sacroiliac in the posterior. And here is the consolidation of all the contours of these patients with these ugly tumor, the expansion of 1 centimeter of here of the DTB and the dosimetry. If you see here in the bladder, that's marked on the lower, the Tmax of the bladder is 2,700 and from the left to the right, the Dmax is less than the prescription dose. I wanted to highlight this as well. Thank you very much. And this case, as you saw, received short-term radiotherapy. Back then, we didn't have the rapid published. So we followed the schedule of the University of Washington with 4 cycles of 4 FOX. Had surgery in 2017, June, radiotherapy, and then in January, surgery was 5 months later. The patient was at the hospital after 2 months of chemotherapy. They had surgery. This is the biopsy of the surgery. Look at the arrows. The bottom left, 2 centimeters without no identifiable neoplasia. No metastases in the middle. The regression score, grade 0, with no evidence of residual tumor. Recall that this patient had a huge tumor. It was very, very ugly. And I controlled him. Last week, I checked him. The patient, it was 6 years ago. The patient has a normal life. He even goes to the beach. He has no colonostomy. He weighs 90 kilos. The only alteration is that instead of going to the bathroom and for stools one time a day, he goes 2 or 3 times a day for that has good continence, and the antigens are totally normal. So this is a great ugly case that cured with short course radiotherapy and only 4 cycles of folks. And the last one, but that basically I want to show you the image due to time issues, is a patient with a low rectal cancer. The counter that you see in the red is not STV, it's PTV. And I want you to see the actual plane where you can see the uterus that allows to separate the rectum from the bladder. This patient also, we had more than we wished we had a full bladder. And I couldn't function the MRI, but yes, the PET scan. Let me show you a scanner with empty bladder so you can see the impact. The tumor is totally outside of the PTV. I don't know if you can see the actual plane, the rectum, totally out of the PTV. And for me, this is very concerning. And we should try to change in our practice as much as we can to consider these displacements. If we have the possibility of convening CT, use convening CT ideally. If you don't have that possibility, then I believe patients should be simulated with full bladder and then with empty bladder. So you can make an ITV of all the positions where the PTV is going to move and consider this. Here you see with the PET, you see the area of hypercaptation in the rectum. Most of the tumor in this actual plane is outside, plus 1/3 of the tumor that you can see in the sagittal plane. So just to call your attention that of something that does happen, and if before convening CT we were not aware of these, well, we need to approach now in a different manner. So as conclusions, this is my final slide. TNT is a standard. There are several reasons in favor of TNT with hyperfractionated and folks according to the fast schedule. For me is course. This is the most important thing for me. That's why it's highlighted in black. The analysis of 9 randomized studies comparing the hypofractionated versus long in advanced rectum tumors. 8 of 9 local tumors are equivalent, and the only one with a difference has reasons to explain that difference of 4% in local control. The quality of radiotherapy is very important, as well as the quality of the surgery. I believe that in the ideal world, IRT with RRJP, in a non-ideal scenario, excuse me, of course, a good 3D with good course, and considering the movements, making the simulation with empty and the full bladder, which is not a large investment for the radiotherapy center only. It will take a little bit longer. Probably we can improve our results. The quality of the surgery is important. The surgeons already taught us that PNE is important, and now on the locally advanced, if we had planned and the patient has no complete response, there is no need to change the plan for anterior resection. I believe we should continue with the mild because the ugly tumors have a greater response. Hypofractionated and FOLFOX can be a good non-surgical treatment option. Thank you very much. Excellent lecture.